I drove all the way out.
Oh, did you?
That was
I
probably
drove
smart.
50 miles for rather than 15.
It was probably still quicker.
Maybe you're so worth it. So I'm gonna introduce, I'll let Matt tell you about his background and everything. But we did list it on the website as well. But Matt DeWild, actually, I'm a patient of his as well, so I give him a thumbs up. I think he does great work. And so I'll let him explain exactly. There's so many components of what he does. So I know he does a little bit of active release technique, and we've done that, but there's so many other things that I never know how to explain it, so.
That's all right.
I'm gonna let you.
Okay. Well,
You
thanks.
explain it.
Thanks for having me in. As Lisa said, she's a patient of mine and has been coming in to see me. Was telling me a little bit about the healing group that you guys have for autoimmune disorders, which is very intriguing, and I thought it was a pretty cool idea. And she asked me to come and give a little talk, so that's what I'm doing. Right? So I apologize. You kind of get me as I am today. I had to rearrange my schedule and just kind of at a couple of factories today treating patients. So my background, I'm actually a registered nurse. I have a massage therapy license as well, although I don't really do massage therapy. Been practicing for 20 years. The last 5 years has been more focused on pain issues and dealing with that. That's really evolved over the last couple of years, and now we're getting into all kinds of different, more complex medical conditions, right, that people come in for. Big paradigm shift in patient thinking, I think, that's happening. Patients, clients, they're looking for alternatives to some of the traditional medical care that's out there for a variety of reasons. Either conventional medical care hasn't gotten them the results that they're looking for, side effects associated with that, risk associated with certain procedures or pills or whatnot. And so a lot of people are looking for a more holistic approach, more natural approach to dealing with some of the issues that we have. Again, typically people started coming to see me for pain issues, and I would use a lot of active release techniques and cupping, soft tissue mobilization, some instrument work, this type of thing, and we had really good results with that. But those are all addressing kind of structural hardware issues, right? So a problem with a tendon, a ligament, a muscle, a fascia, something we can put our hands on, something we can see on an X-ray, an MRI, something like that. Something structural, something hardware related. And we had really good success with treating that, but then there was always that segment of patients where you just couldn't quite get them to where they needed to be, and so there was something else going on there, and that's where we really started looking at the neurology of what's going on and more of the software of things. And then once we really started diving into that and really developing a system where we could assess the software side of things, the neurology, the processing in the brain, and then a method to treat it, really opened up a ton of new options available for dealing with a variety of issues, not just pain. If we think about it, the brain runs the show, right? It controls every body process that we have. And therefore, it's kind of the source of things that we need to go to. And if we can have an effect on that, that will have an effect in turn on, say if we're dealing with a muscle that's chronically tight all the time, right? Well, the brain is telling the muscle to be tight, right? And so we can address the muscle and make it loosen up or whatever, but if the brain's still telling it to be tight, it's gonna be tight sooner or later, right? So that's why sometimes you can release a muscle and it's pretty good for a while, but pretty soon it tightens right back up, right? So one, addressing that area where it may hurt isn't always the source of the problem, right? So we gotta look somewhere else and find out what's causing that, right? And typically what we find is it's on the neurology side. So the brain's getting bad input from somewhere, might be the area that hurts, might be something totally unrelated or seemingly unrelated. The brain's making decisions based on bad information coming in, and then so there's a bad output of information. And that can be a tight muscle, a weak muscle, whatever, something that doesn't function correctly. And if we can address those things, then results happen very, very quickly. Within seconds, typically, we can have an effect on that. And then so we start talking about, the application, for pain type of syndromes, sometimes we still have to deal with these hardware issues. But then we can also deal with the software side of it as well, so we get a more complete package with that. Now, sometimes problems have been going on for a long period of time. Things have been working very inefficiently. The biomechanics are off, and we create a wear and tear, and we actually create a structural damage to something. So I equate that to like a knee problem, right? So I got a bad knee, and it gets degenerative, and sooner or later I'm bone on bone, and the doc's saying I need a knee replacement, right? Well, maybe you do need a knee replacement at that point, right? If it's all wore out, and sometimes that's what we need to do, is go in there and replace that and fix that structural damage. We have to do those things, but the problem is it doesn't address how we got there, right? There's some process that was going on, some weakness, some inefficiency that led us down that road to that degeneration. It didn't just happen, right? Unless you got hit by a train or something like, some traumatic injury. But these degenerative things don't just happen. There's a process that's going on. So even if we have this end result of this damaged knee, and we go and we fix it, we put a new knee in there, new joint, we still haven't addressed the process that got us there, right? So that process is still going on, and these people continue to have knee pain, or maybe now they have hip pain or ankle pain or back pain or whatever, because this inefficient process is still going on. It hasn't been addressed. It's not addressed with surgery. It's oftentimes not addressed with physical rehabilitation. So it's another subset of things that need to be looked at. And unfortunately, that's just not done very much. So that's where I come in and try and help out with that. Now, you expand that out to what we're talking about here, autoimmune disorders, right? Whether that's lupus or scleroderma or psoriasis, rheumatoid, I don't care, take your pick, right? Autoimmune. It's the body attacking itself, right? And as we all know, what's the number one thing that will flare up an autoimmune disorder? Stress, right? Stress is to be avoided. And when I say stress, I mean it a little bit differently than how most people take it. I do mean that mental, emotional stress that we commonly think of, but stress comes in all forms, right? So there's that mental, emotional component to stress that puts stress on the body. There's physical stress, right? That's coming from either inside or outside the body. So pain issues that creates a stress to the body. Inefficiency of muscle movement or muscle patterns or movement patterns that we do will create stress to the body because we're not operating at an optimum condition. Nutrition, right? Either a deficiency in what we do need or an excess of things that we don't need. Either way is causing a stress to the body. We have environmental factors, things that we're exposed to, chemicals, some things that we do to ourselves, right? That we put on our skin or that we're exposed to. Again, things that we eat, things that we breathe. Exercise. Exercise is a stress, right? Now, in the right dosage, it's appropriate and it's helpful and there's benefits to it. But any amount of exercise is added stress to the system, right? So if you got all these other things going on and then you go do a hard workout, you're just adding to that total stress level, right? Putting that in there. Now, I'm not saying don't go work out. That's not what I'm getting at. But if we can reduce some of these stressors, then one, there's a lot of health benefits, but let's relate it to autoimmune, right? If we decrease that overall stress load to the body, right, the immune system is going to function much more properly, okay? That's true of anybody, whether they have an autoimmune disorder or not, right? They're going to function much, much better. Their immune system is going to be better. The cardiovascular system is going to be better. Start talking about sympathetic and parasympathetic overdrive. And those components there, all of that's going to function better if we can reduce the stress that happens to an organism. So some things we can control and some things we can't. So our nutrition, right? Eliminating the things that we know are inflammatory, things that are not good for us. Some things we don't even necessarily realize. A lot of people have food sensitivities that are not allergies, right? So you can be sensitive to a particular food that causes a abnormal response or an adverse response in the body. Well, those are things that should be avoided, right? Even with your food allergy testing, even by drawing lab work, and we can see spikes in IgG and IgM, we can analyze all of that. But all the studies that you look at, when they try and correlate that with people's symptoms, it's very poor correlation, right? So even though you know you eat something and it doesn't agree with you, right? You have an inflammatory response, you have some adverse outcome from it. You don't feel good every time you eat this particular food. Yet you get tested for allergies and no elevation in your immune markers, right? So they say, well, you're not allergic to it. Well, doesn't mean it's good for you, right? So you should probably avoid that. Likewise, there's people that they spike high on things that are food allergies, but they can eat it and they feel nothing, you know? So there's not a good correlation between the symptoms there. So if you start talking with like a lot of the functional medicine doctors, and that's an emerging kind of field in preventative and holistic care is functional medicine. And if you start talking with those guys, they'll say forget the food allergy stuff and keep a food log, see how your symptoms are, and then base that off of what you can eat or shouldn't eat. We talk a lot about doing a paleo elimination diet and then gradually adding things back in to see what you're sensitive to, right? So that's one way that we can kind of decrease some of those stresses that we have. My specialty, or the area that I focus on, is neuropathway dysfunctions. I do a lot of other stuff. I do the active release techniques, I do cupping, I do instrument stuff, I do a lot of things. But the area that's kind of specialized and very unique, because nobody else is really doing that, certainly not in this area, is looking at these neuropathway dysfunctions. So that's all the way down to the neuroreceptor level that we have in our skin, in our fascia, in our joints, these nerve receptors that are tuned for different sensory inputs, right? So we have all these different nerve receptors. They're all tuned a little bit different. So we have some that are tuned for vibration, some that are tuned for just real light touch, some for deep pressure, hot, cold, you name it. We have all these different types of receptors. In addition to the receptors, we have neural pathways that connect in the brain. Okay, some of those go through the spinal column, some of them don't, depending on what we're dealing with. But those pathways can become dysfunctional as well. Or in the brain, we have a dysfunction in how information is processed. Right, it's not processing things correctly in the brain. So again, we have some discourse around those signaling, and we get a bad output, right? So I look at addressing, one, identifying where those dysfunctions are, what they look like, what types of dysfunctions they are, is it related to this particular type of receptor, is involved in this particular neural pathway. Once we identify that, we can create a stimulation for that and do kind of a reset in the brain, okay, and bring those back down to normal. And that happens really, really quickly. If those neuro pathways are contributing to a pain syndrome, a pain condition of some kind, that pain generally goes away just as fast, within seconds or so. Now, my experience is pain conditions generally have multiple sources. It's never quite that easy where there's a silver bullet, but sometimes there is, right? And so you have to address maybe a lot of different factors, right? But every factor that we can address, when we start knocking these down, the better off people are, right? The more efficient they become, the less inflammatory response that they have, the less pain that they have. So we start, bringing all these down, and hopefully we get enough of them down that people can live pain-free or pain manageable is what we look at, right? Because sometimes, depending on the condition, depending on how long it's been going on, the damage that's been done, pain-free isn't always a realistic goal for people. I mean, I wish it was, but it doesn't always work out. So sometimes we have to look at things being pain manageable. So back to the neurodysfunctions, the neuropathway dysfunctions. Kind of what happens, and the best way I can describe this is we have a neuroreceptor or a neuropathway that becomes dysfunctional. It's not working properly. Now, normally we have kind of a normal amount of signal that comes out of this receptor or pathway that goes up to the brain. And it's fairly constant. It fluctuates up and down a little bit, but it's at a certain rate. When these become dysfunctional, what happens is they start sending too much signal. Okay, so it's really hyperactive. And in these areas, we tend to see a lot of tension in the muscles or the fascia or whatever. We're getting too much signal to the brain. Brain doesn't like that. It knows that's abnormal, and it tries to create compensation in the system, right? So we've got this one, this primary one that's really elevated, sending a lot of signal, and the brain immediately brings up another one to try and balance the system out. So it can't tone this one down. It tries that first, but when that doesn't work, then it brings up another one to try and balance it out. Now this one's sending a bunch of signal, too much signal to the brain. Sometimes this one's enough to compensate, sometimes it's not. If it's not, then there's maybe 2, 3, 4, 100, I don't know, that come along with this one to bring compensation to the system, bring balance to the system. We're always looking for this primary one, and we're looking for this main secondary. There's always going to be one main secondary involved here. If we can stimulate both of those in the right way, to send the right signal to the brain, so it's already sending too much, right? We're actually going to rev that up a little bit on both of these, and we create a quick reset in the brain will immediately drop them both down, back to where they're supposed to be, okay? So we're always looking for these pairs. We're always going to work in pairs like that. Now, in addition to the pairs, to make this more complex, is these pairs are grouped together in what are called fractals. And these fractals arrange themselves in a hierarchy, if you will. So we can have a pair of receptors here, kind of low on the food chain, if you will, and we rev up both of these neuroreceptors and we reset them. This goes away. So if we go back and check this, it's gone. So that's a good thing. But again, if this was low on the food chain, there's other ones above it. As soon as you stimulate one of these ones above it, it comes right back, almost instantly, just as fast as it went away. So this is why sometimes maybe you went for a particular type of treatment and you feel pretty good. You get off the table, hey, I'm feeling pretty good. But later that day, the next day, 2 days later, a week later, whatever, you're like, it's back. It's back, same exact thing. Probably treated a lower level dysfunction in some way and improved it. There was something else to stimulate above it, so it came back. So we're always trying to look for the higher level dysfunctions, because if I get a high level dysfunction, especially one at the top of the food chain, same treatment, I find the pair, increase both of them, reset in the brain, this one goes away, but so do all the other ones connected to it below. So they all go away, which is very beneficial because we don't have to do as many resets because your brain's only going to tolerate so many of those in one particular sitting. So if we can get that top level one, we get that one to go away, all these other ones go away, and all their associated muscles, dysfunctions and whatnot, all go away with them. And if there's nothing left to re-stimulate it, then they'll stay away. Now sometimes we have triggers that will create these dysfunctions that we either can't get rid of or are very difficult to get rid of that are still persistent, that create dysfunction. If we get a top level dysfunction here, we fix it and all these go away, but we still have a trigger. That trigger will create a new dysfunction, or it can create a new dysfunction, but it won't be the same ones. It'll be a different one. So that person comes back in a month or so, and I look at them and they're like, yeah, I got the same symptoms, but I go back and I'm like, okay, well, we fixed this the last time, right? And if I go back and I check for this, it's not there. It's different receptors. The brain is compensating in a different way. Symptoms may be the same, but when we isolate out the different types of receptors, it's going to be a different pattern. So that can be a little bit tricky. How do we find these? How do we treat them, right? Typically we use manual muscle testing, okay? The brain, like I said, runs the show, but it's in response to stimulus that it's given, okay? So the brain responds to input, right? It gives an output. The brain can respond in a couple of different ways. It can increase or decrease glandular production, so different endocrines, different hormones, right? It'll either increase those or decrease those in response to a stimulus. We know that happens. The problem is it's very difficult to measure, right? So if you're in my office, I can't just give you a stimulus and then draw some blood real quick and then throw it on a machine and, okay, what is it? Yes or no? It doesn't work very well. It's not very practical, especially if we're going to do 10, 12, 15 corrections in a second, right? So the other way the brain can respond is through facilitating or inhibiting muscle activation, muscle fiber activation to be more specific. So the brain, in response to a given stimulus, will either facilitate, increase the amount of signal along the gamma pathways to a muscle fiber, and the muscle will become more active, stronger, if you will, or it'll inhibit that signal going to the muscle, and the muscle will become weaker. Okay, and that's something that we can test very, very quickly and repeatedly in the office. Manual muscle testing has been around since the 1940s. Kendall and Kendall first really kind of described and put together a system for that. It's certainly evolved over the years, and it's the way we're using it here is more that neurological connection as opposed to strictly testing muscle strength. Okay, so Kendall and Kendall really came up with how to test muscle strength of a isolated muscle, as they called it. You're never really testing a muscle in isolation, but for our purposes here, we'll say we are. How to test the strength of it. We're really looking at how the brain's response to something affects that, right? So pretty profound when we can do that. So we can demonstrate this. So any volunteers? Who volunteer?
Well, today is not the right day to do it, but
It's got a lot.
I've got a lot going on, so I'm going to.
Maybe it's the perfect day to do it
do
then.
anything first, though, are you? Because I don't like that. Oh, okay. All right.
So let's just do some simple strength testing. Okay, so let's just bring this arm up, straight elbow. I want you to push up into my hand, right? Push up into my hand. Arm's nice and strong. Okay. We know there's certain stimuluses that should create a weakness, right? So we tweak your nose a little bit, right? Go ahead and push up for me now. Push.
You're pushing harder.
That's what they all say. Push up there. Push. Actually. Yeah. So you're strong when you should be weak. So a stimulus to the nose like that should make somebody weak.
What does that mean?
Well, that means you got a problem going on.
I'm obstinate.
Yeah. Try that again. Push. Yeah. So this is what we call globally hypertonic. Relax. Relax. So we look at muscle testing. We look for, again, how the muscle responds. Is it strong? Is it weak? Right? Well, if it's strong when it's supposed to be strong, that's good. If it's weak when it's supposed to be weak, that's good. If it's strong when it's supposed to be weak, that's bad. If it's weak when it's supposed to be strong, it's bad. Kind of related to lab values, right? We have a range of lab values that's normal, right? And then we get outside of that range, whether it's low or it's high, we say that's abnormal. And typically we're looking at pathology and that kind of stuff. Same thing with this. If you have a muscle that tests strong when it's supposed to be weak, that's like a high lab value. Or if you have a muscle that's weak when it should normally be strong without any stimulus, then that would be like a low lab value. And all of those are abnormal findings that we would want to address. So tell me this, are you having particular pain anywhere today right now?
No, just mental.
Okay.
I've had a really stressful
Okay.
couple months.
So we also talked about, right, stress overall creates an effect, right? It is not a foreign concept to understand that mental stress will affect the physical body, right? I think we're all on board with that these days. There's a lot of resistance to that. There's still some, but can have a profound effect. So why don't you take your other hand? And I want you to touch right up here for your head, not mine. There you go. More right there. Good. Bring this up for me. Good. Go ahead and push up for me. Push. Okay. I want you to touch on the other side. Right up there. That's good. Push up for me. It's a little bit weak. Put it over here. Think about what's been modeled.
It's a long list. So
That's
sorry.
okay. Just whatever comes to mind. You don't even have to tell us what it is, right? Good. Yeah, hold that up for me. It's pretty weak. Pretty weak. As soon as you start thinking about it, right? So that's an emotional correction that we would want to do. That's what's creating this, when we said the global hypertonicity, right? Is certainly some mental or emotional component there. And that's something we treat in our office as well. And again, through this neural pathway type of testing, we can make a correction to that. So what's happening is you've got this issue, or multiple issues, as you've said, right? But you have a issue, at least. There may be multiple ones that's actually creating this global neurological effect for you, right? When I fix things, and I have to explain this to people, right? I don't take away the problem, right? The problem is still there. But what we do is we take away that neurological deficit that it's creating, okay? And sometimes when people, they're going along, they're dealing with their stuff, but they get stuck on certain things, a lot of times it has to do with this. There's some theories behind that. Nobody's really been able to prove it, but I tend to agree with the theory that if your brain knows that this is creating a problem for you, it's going to avoid going there on a subconscious level, right? It's just going to avoid that. And I think that's where people get stuck in trying to get over their issues and their problems, right? If you can't deal with that on a subconscious level, you're going to have a hard time getting past it. So if we can remove that neurological barrier, right? A lot of times people do much better. Which one have a seat? Yeah.
What about torticollis?
Torticollis, that's a hyperactivity typically of the SCM muscle. Typically there's some other components to that where it's hyperactive, right? And it's locked down. We have to determine what the cause of hyperactivity is, right? Oftentimes we can use neurological corrections to tone that down, right? And it gets some pretty good relief from that. Fortunately with torticollis, it's fairly refractory. It doesn't respond well to a lot of standard medical treatments, right? So standard medical treatments give you muscle relaxant, right? Or lots of muscle relaxants in some cases.
Work.
And a lot of times you'll find that it doesn't work, right? So
massage helps better, or like a warm shower.
Right. Here's why muscle relaxants don't work. You would think, well, if it's a tight muscle, I give it muscle relaxant, it'll get better, right? But with torticollis, typically what happens is there's something that's not working well, okay? Something that's weak, right? And the muscle that's really tight is an overcompensation for that, right? So we have this out of sync, out of balance type of thing, right? So we take a muscle relaxant, we drop them both down, but we still have an imbalance, right? That's why it doesn't work, because we still have that imbalance. You've got to get these two closer together. You got to tone down the muscle that's too tight, and then ideally you want to bring up the muscle that's too weak if we're dealing with muscles. There'll be a lot of other things involved, but just for the sake of argument, let's say it's two muscles. Yeah. And that's why massage of the tight muscle will tone that down a little bit, right? Now, if we can simultaneously facilitate the other one, then we're going to get those a lot closer into balance and things are going to be better, okay? Now, keeping them there, that's kind of the trick, right? Because there's a lot of things that can affect that. But torticollis is a great example of one thing not working correctly and something else being a really bad compensation for that. Low back pain is a classic example of this, right? Low back pain, people come in, let's say again, you haven't jumped off a 20-story building, you haven't been hit by a train, you don't have some big traumatic event like that, but you've kind of got this chronic back pain. Typically that's muscular and fascial in nature, right? Most of that pain is generated from there. Well, why is the muscles, and you go in and you see your chiropractor, you go in and you see your massage therapist, and like, oh my gosh, why is that so tight in your back, right? Well, it's because something somewhere else isn't working correctly. And so that's trying to create compensation to create stabilization around your pelvis. Typically that's the abdominals, okay? Weak abdominals. That's what we find most of the time. There's other possibilities. That's why we always test, right? Don't guess, test. Here's the problem with that. So, oh yeah, your back's really tight. So you go in there, you try and you want to release that so it'll feel better, right? If that's the last thing holding your spine together, creating stability in your spine, then that's a problem, right? You got to address where the problem is, right? You say, okay, we've identified where the problem is. It's a weak core, so I need to do core exercises, right? Well, here's the problem with that. If your brain's not engaging your core and you're trying to do something to facilitate your core, your brain is just going to compensate somewhere else, right? Typically in that low back area that's already tight, right? Or somewhere else, or all of the above, right? You can actually make things worse. You've got to turn it on in the brain first so that the core works, and then you can train it if you need to. If it's been weak, if it's been offline, if you will, for a long period of time, then you can train it at that point. Now here's typically what happens. There's a little bit of that going on, but then there's also a part where we can get the abdominals to engage, but we have to stimulate something else in order for that to happen, right? Which works temporarily until that mechanism gives out, and then it doesn't work anymore, and then we get injured and we have all kinds of problems. But it'll work for a while, and then the brain maybe will move on to something else, and you can stimulate that, and it'll make the abdominals engage. But that's not a very efficient way of doing things, right? So you tire very easily. You don't really get the core development that you're looking for. Okay, I'm not saying you should do it. I'm just saying it's not very efficient. So somebody else less stressed maybe today.
Who's that?
Is that nobody today?
I'm sweating.
Okay.
I'm sweating.
I'm sweating too. I'm always sweating.
Sweaty doesn't bother me. I deal with that all day. All right. So, any problems with your shoulder? No. Okay. Let's take a look here.
Just my knees.
Just your knees. Okay.
2 new knees.
2 new knees. All right. Push up against my hand here. Push up. Okay. So you're getting strong there too, right? So a little stimulus and push up on that one for me. You're hypertonic too. Either that or I am. I'm not really prone to that, but some people are. Go and push up for me. Push. Okay. Let's just try the other arm just to make sure it's not there. Age?
It must be our age.
Age.
It's not age. Yeah.
Hypertonic.
Matt, what did you say? So it's
Push up.
it's
Did your knees hurt? Knees hurt?
Okay, not very much.
Anything hurt in particular right now? Back, neck, not overly stressed? Okay. Where do the knees typically hurt? Right in the front? Sides? Just all over?
The front.
Yeah, I'll probably more front.
Yeah. That's where most people tend to know, right in the
Right here.
quad tendons.
Yeah.
So let's just rub that for a second, right? That's good. I got it. Push up for me. Push up. Relax. Light rubbing like this will block mechanoreceptor signal to the brain for a few seconds. So if that's a problem,
What
push.
does the nose do?
It's just a known stimulus. So if you tweak up on the nose a little bit, all the muscles on the front half of your body are weak for a few seconds. If I tweak it down, all the muscles in the back. Okay? There's different things we can do to kind of turn muscles on and off or whatever, but thanks for playing that.
so, sorry, can I
Yeah,
ask
go ahead.
you? You said, or I'm taking notes. I'm not texting. You said if your brain knows on a conscious level that something's bad for you, it will react in a negative way to keep you away from that.
There's theory out there, and I tend to agree with this. If your body knows, if your brain knows that a certain thought, emotion, whatever, is creating one of these neurological deficits for you, right? On a subconscious level, it's not going to go there. It's not going to go to that memory, that emotion, that issue, whatever it is, right? Because it knows it's creating a problem. And I think by not going there on that subconscious level, right, that's where we get stuck in our stuff sometimes. And that's why hypnosis or even talk therapy, psychotherapy, can be helpful because it totally focuses on taking you there, right? So that's why sometimes that can be very helpful in resolving some of these issues. But just left to our own devices, sometimes that doesn't work so well, right? And again, it's theory. Nobody's really proven that, but I tend to see that quite a bit. I do a lot of work with a women's shelter here in town. I do work with a drug rehab facility. So we deal with a lot of emotional issues, right, related to this. The women's shelter that we're at, we're getting people off the street, we're getting people out of the prison system. We get a lot of trauma, a lot of baggage, a lot of this kind of stuff. So we get a lot of opportunity to work with this kind of stuff. And there is, emotional corrections that we can do. Typically, we have to do them one at a time. We have to be very specific. So we pin down what an emotional component is, but then we pin down what subcomponent it is. Is it something that you've seen in the past? Is it something you anticipate seeing in the future? Is it something you've heard in the past? Is it something you're anticipating hearing in the future? Is it kind of that self-talk, self-dialogue, the inner dialogue that you have with yourself? We're trying to break it down to those components so we can get to things much better, much at a deeper level, right? And so if we're able to do that, we're able to, at least temporarily, take care of that emotional component that we're dealing with. You still got to deal with your stuff. That's what I always tell people, right? It doesn't take away your problems. If I can figure that one out, probably take that show on the road, right? You still got to deal with your stuff. So the muscle testing, right? So people still want to see the muscle. How about Lisa? Come on, because I know how she reacts already, and I know what her triggers are, so I can kind of take them away pretty quickly if I have to, right? All right. So again, we'll just start with some arm stuff, right? So push up for me. Push. Okay, so we got the exact opposite problem here. All right, let's make sure it's not showing. It's globally weak, right? So everything I test is
I
weak.
flew today.
Yeah,
I was fascinated.
turn in like this. Good. Hold it in towards your side. Okay. So everything's weak. But let's see here. Hold that up for me. Push. You don't become strong when you should. So that's a bit of an issue. Did you, what are you eating? Peanut butter? Nuts? Nuts? What's that? Nothing to know of.
Sensitivity to it.
Very smart.
If I will get it out of her system.
No, but it takes it out of her mouth temporarily. Yeah,
Her brain just almost.
just temporarily. Just like that.
No, if I am.
Yeah, still pretty weak. How about, said you're flying today, huh? Blow out like you're trying to pop your ear. Good.
Well, that's what was happening today.
Yeah. Good. Stop.
They're still not all the way popped.
Strong. Push.
It's my ears.
Yeah, it's your ears. Push. See, it's strong.
Because I was sick before I left. So the way there was like,
Yeah.
that was so hard. There was a woman in that restaurant that said to get earplanes. They're called.
Earplanes? I haven't heard
Put
of
them
that.
in your ears while you fly.
Okay.
Do what?
I just kind of suggested.
I don't know about airplanes.
That's what
They
they.
still sound a little science.
Yeah.
Okay. Right here. Arms up. Push. Push. Pretty strong.
That's better.
Much better. Push. Pretty strong. Okay. So now it should respond normally. See? Push. So a little tweak of the nose just puts her right. Now can we make her strong again? Let's see. Push. Push. Yeah, so it becomes strong like she's supposed to. Other stimulus, this kind of freaks people out a little bit. Parallel lines, X. Okay? When you look at parallel lines, they're approximately 18 inches, 18 to 20 inches from your face. All the muscles in your body should be weak. When you look at X lines, they should all be strong. Okay? Why does this happen? Well, again, we're back to theories, right? But we think the parallel lines at that distance separates both eyes, right? And so we don't get a lot of crossover in the brain, or we don't get as much crossover with the corpus callosum. And so the brain doesn't like that, and it creates a weakness. Whereas this one encourages this type of movement. So, arm up, push. This is another way that we can test, right? So look at the parallel lines, push, pretty weak. Look at the X, push, and back to being strong.
It's not
So
normal, is it?
that's actually responding normally. Now, what did I do though? I adjusted some cranial faults, right along the zygomatic arch, which deals with drainage from the ears. So a lot of times if people have plugged up ears or whatever, a lot of times there's a cranial fault issue. It could be TMJ problem, could be a lot of things, right? But a quick go-to is the zygomatic arch, and we create just a slight shift in that, and it's enough to free things up. You know, I would do a lot more work to be honest, or something like this, but something pretty quick. You're like, yeah, you sound a little sinusy. I had a cold before I flew. You had pressure changes today. That's likely an issue, right? So again, so now we've got a normal testing subject, which is always good to work with, right? Any stimulus, any neuroreceptor that we deal with, if we give enough signal to it, we can artificially create that hyperactive signal, right? So one of the common ones that we see is crude touch, just this light touch across the skin, right? And so if I give enough stimulus to it over and over again, I kind of create that hyperactivity of that type of receptor. Give it too much, right? The brain's not going to like it. Okay. Go ahead and hold that up for me. Hold that up. Hold that up. Nothing. Now, so I said before when it's out, right? when he was up here, we're blocking some mechanoreceptors by rubbing. That's the same type of rub, so we can block those types of signals. With crude touch, though, it works on a different neural pathway. And so to block those signals, we have to apply pressure. So if I apply pressure for a couple of seconds, I've now blocked that bad signal going to the brain. Push, and now she's strong again, right? I've only blocked them for a few seconds. So if I wait a few seconds, it'll go weak again. Or if we just give it a little bit of stimulus this time, it's probably enough to push her right over the edge. And she's back. Given your pressure changes and some of the things going on, normally when I do this, it wouldn't create like a permanent dysfunction, right? It would just last for a few seconds. Unfortunately, I think for you, probably created a dysfunction there. It's all right. I know how to fix those. And we can test for that. So that's an example of testing a muscle directly, right? Yeah. So I stimulated receptors that are in the skin, in the fascia, right through here to create a weakness of the anterior deltoid muscle, right? Which is essentially what I'm testing when she's right here. Now if I bring her arm to the outside, out here, we're looking at more middle deltoid, right? So hold that up for me. Strong, right? But that's not where I stimulate. I stimulate here, so more anterior deltoid. Hold. Doesn't work, right? So that's how we can directly test a muscle. But what if somebody has a pain condition that they're coming in with, right? And we need to assess an area, but I can't test it because it's too painful, right? So then that becomes problematic. We don't want to. We'll get to you. We don't want to keep trying to test that because that's painful, right? We can test by using another muscle in the body, okay, as an indicator muscle, right? The brain will respond to it the same way. One of the ways that we can do that is to, one, hold a tendon. So go ahead and just, this is our tendon. Just push on that a little bit, right? So now, any stimulus that I give, here or anywhere in her body can be reflected in another muscle. So I don't have to test that muscle directly. So while you're holding that, let's hold this one up, make sure that it's still strong. It's still strong, okay? We know that this crude touch over here creates a weakness in this muscle because that's where it's located at. But now with this technique, I can do this, hold this arm up, make that arm go weak. And actually it'll work with any muscle in her body. Stimulate that because it's dysfunctional. Go ahead and just hold your thumb back for me. Right? I can check her toes, I can check her hip flexors, it doesn't matter. It's going to be weak. And it just lasts for a few seconds, right? Push back.
My ear just popped.
Yeah, you're probably going to get some drainage now from the adjustment I did earlier, but that's okay. Okay, so that's a way that we can use another muscle to test what's going on. And that's frequently what I do. So we're not, because a lot of people are coming, if you get really a lot of dysfunction somewhere, you've probably got pain there, right? Or things that aren't working correctly, so we can't use that. Now, what do you do if you have a child or an infant or somebody that's had a stroke? They can't cooperate with the muscle testing, right? So my 5-year-old son has sensory processing disorder, dyspraxia. He doesn't process input like everybody else does, right? So hypersensitive to like tags in the back of the shirt, food that he eats. Every sensory stuff is just like an overload for him, right? So I got to try and decrease a lot of these. A lot of it's crude touch, right? So we want to try and decrease a lot of those. But he can't, at 5, he can't cooperate with the muscle testing, right? So what do you do? Well, that's where you can use a surrogate tester, right? So, we'll see if you can help. I don't know. Maybe. Let's see your arm, right? But just push up, nice and strong, good. Push. Yeah, goes weak. It's supposed to. Let's put it back strong. Oh, good, nice and strong. Okay. So let's say Lisa. No, stay here. So let's say Lisa's incapacitated, or for whatever reason we can't test Lisa. She can't test directly. So I can bring a friend over. Now we know that this area is dysfunctional, right? Because I made it dysfunctional. So you touch her there. Fingertips. It really works with fingertips. And tongue, and nose, and tips of your toes, but fingertips are better. Hold your arm up here. Hold it up. Weak. Take your hand off. Hold it up. Nice and strong. Touch her in some random spot. Appropriately, please. There you go. Hold that up. Nice and strong, because there's not a dysfunction there. Touch her where she's dysfunctional. We know she's dysfunctional. And here. Oh. Goes weak. So I can use your neurological system to test her. So how does that work? How does that work? Because when we're touching an area, the area that we're using is like an antenna. That's a receiver, right? And so this is picking up on that hyperactive signal, right? That's going to her brain. Now normally I could test her because it's going right to her brain. Your brain doesn't really know the difference, right? All it knows is that, wait a minute, now I'm getting a bunch of signal that's not right, okay? And so we can test you. Same thing, so once a month I go down to an Amish community in southern Iowa, okay? And I've gotten to know them pretty well. I got started, was at a sale, met a guy, an Amish guy. We're in his barn, he's got a shoulder problem. I fix his shoulder problem in the barn. Pretty soon he tells everybody and they're all coming from miles around in horse and buggy, okay? So I go down once a month, and I was down there Saturday, spent all day, went to about 4 different houses. They bring us into their home, which is very unusual, very unusual. And their friends and their neighbors all come by horse and buggy, and it might be one person, or it might be, mom, dad, and 10 kids that get out, you never know. I run into all kinds of stuff this weekend, but the strangest was probably a lame horse that had a problem. And he wasn't picking up his hoof very well, right? And they're like, hey, you've been fixing everybody around here. What can you do for the horse, right? And I'm like, well, let's go look at the horse. And we've had horses, so I'm pretty comfortable with that. And I'm feeling, around the tendon and whatnot, because that's typically where we're going to find a problem there. And I don't really feel anything. I don't feel like where they've been injured. I don't feel like a tendonitis or something like that. So I'm like, okay, not structural, probably software related. So what do? Get a surrogate tester. Start touching the horse, seeing the response in the human, right? And find out where the problem is. And then you can correct it, and the horse will walk away just fine. Okay, people get a little wigged out about it, but once you see it, it's pretty impressive. So back to Lisa, right? We don't want to leave her broken. So she's got a crude touch dysfunction here. So we got to figure out, again, this is going to be the primary, most likely. The primary one that's dysfunctional, we got to find that pair. Now, most often, crude touch will pair with fine touch, just a real light, small discriminatory touch. There's a few other things that it pairs with as well. So we're going to find out which one it is. We do a double stimulus here, 2 stimulus back to back, push, should create a weakness. Okay. 2, 3, 3 stimulus, push, push, strong. Okay. Push, strong. That would indicate we're at the top of the food chain, okay? Dysfunctions that occur relatively recently tend to be farther up here. Ones that have been going on for a long period of time tend to produce more below it, right? So we just created this a few minutes ago, so it's kind of top of the food chain. We need to see what it pairs with. So 1, 2, we know that makes her go weak. Now, whatever stimulus it pairs with, if I give it to the same area right away afterwards, we'll make it strong. So we'll try fine touch. Push. It's not fine touch, that would have been too easy. Some of the other common ones is spinotactile. So double stimulus there. We know that makes her go weak. Push. There, I want you to look at the shoulder. Back forward. Back forward. Look back forward. Yeah, push.
Gee.
Aren't I supposed to look?
It's okay.
Keep looking?
It's all right. Look here. Look here. And back. That's good. Push. That didn't help. Okay. Push. There we go. That made it strong. And what did I do? I brushed her eyebrow in the opposite direction. That's supposed to go. That stimulates the hypothalamus in the brain, which is deep in the brain. Actually, spinal hypothalamic tract that goes to the hypothalamus. So her primary problem is this crude touch we talked about first that goes bad, right? The brain, in her case, for whatever reason, and we don't know why, chose to compensate with that spinal hypothalamic tract to compensate for it, okay? Like I said before, we stimulate the primary one, we stimulate the main secondary. we create a reset for the brain, and I typically do that through a deep tendon reflex. It's like a reset button in the brain. So just like when the doctor whacks your knee and makes your knee jerk or whatever, that's deep tendon reflex. We do that with the biceps. We use a blink reflex. Any of those things work as a reset in the brain. Okay? So we just spinal hypothalamic and just confirm that assessment. One way that we can stimulate that is by moving body hair in the opposite direction that it's supposed to go. And it stimulates the erector pili muscle that makes your hair stand up on end. Okay? So it works in the eyebrow, it works on body hair. It only works on the half of the body where the dysfunction is. People say, well, why is that? I say, why not? I don't know why it's that way. So again, using an indicator muscle, go ahead and push here for me. If I just stimulate body hair in the opposite direction, it doesn't work with the hair on your head, push, creates a weakness. Okay? Now, mustache will work actually. If I do the other one, it's on the opposite side of the body, not where this dysfunction is, right? Push. It doesn't create a weakness. Push up for me. Push hard. Push hard. Yeah, that's good. We can use arm hair, mustache, whatever. The other way that we can stimulate that, sometimes this isn't always accurate if it's, especially if I find it's far apart away. So eyebrow to like an ankle problem. Sometimes it's a little hit or miss whether that works or not. The other way that we can confirm this that works on both sides of the body is hyperventilation. So when we hyperventilate and we increase our heart rate, that stimulates that same tract in the brain that goes up to the hypothalamus. So just hyperventilate for me. Good. That's good. That's good.
Just make the noises and faces you make when you see a bottle of venom.
There you go. And hold. And it instantly creates that same weakness, just if we had stimulated, the body here. Okay? So, how do we fix it? We can never hyperventilate, but we already know this works fine. Stimulate this one the way it's supposed to be. Stimulate this one the way it's supposed to be. Look straight ahead. Blink reflex. Resets it in the brain. Now they're both fine. If I stimulate this one, hold it up. Push. Push up. Sorry. There you go. If I stimulate this one, push. Really stimulate it. Push. Strong. Now it's all strong. If I can get you to come back up again one more time. So we know that using a surrogate, we can touch right here and we create a weakness, right? But the dysfunction's gone. So go ahead and touch again.
The same.
Yeah, same spot. You just need your deltoid. Good. Right there. Doesn't create a weakness anymore. And I can really push on it. I mean, totally fine now, right?
So it doesn't have to be, the people don't have to be real intuitive or in sync. It's just you could have somebody come in off the street and.
Now you gotta qualify them, right? You gotta make sure that you have a strong muscle in the clear, as we call it, without any stimulus, that will weaken when it's supposed to a given stimulus, which I checked, right? And that's okay. Now, when you bring a surrogate in and you do surrogate testing, you're bringing that person's baggage too, right? So I mean, dysfunctions that they have.
Sorry, Lisa. Forgive me.
So if you get kind of wonky results with that, you better double check with another surrogate. Just to make sure. It just becomes slightly less reliable when you're doing it that way, because you're dealing with now two nervous systems, or actually three if you count mine, because I'm touching, right? It can just make things a little more complicated. So if we do surrogate testing, sometimes we want to verify that stuff. There's different ways we can test, so I can kind of self-verify that. But if that's not working out right, then I might grab a different surrogate. But thank you. Lisa is easier for me to work with because I know her history. I know how she responds to testing.
Can I eat nuts?
Well, we could check that out, right? And so that's another way you can use muscle testing as a brain response, right? So again, all we're doing with the muscle testing is testing the brain's response to a stimulus, right? So if we have a suspicion about food allergy or food sensitivity, right? Put a little bit of food in their mouth, check their muscles, see if they get a bad response, right? There's a lot of people out there now doing muscle testing. I've seen them. I've talked to them. I've played with them a little bit. A lot of people don't understand some of the intricacies that that we're dealing with here. They don't know what to look for, and they don't know what normal is, what a normal response is. They have no idea about using cartilage in the nose. I can do the same thing with cartilage in your ear. I can shut off almost any muscle in your body with the talus bone in your ankle. Okay. So a lot of people out there doing muscle testing, they don't understand what normal is and what normal variants are, and so the results they get are a little bit wonky. There's some very good people out there that have been doing it a long time that really understand this stuff, and they're pretty good. But you'll see a lot of other people, like I see people testing for nutritional supplements, right? So is this the supplement that you need? By the way, I'll sell you those. I got them right over here.
Mm-hmm.
You know, I always get a little wary with that. But there is actually a way to do that and a way to do it correctly and ethically. But oftentimes what I see is they'll come in, test the arm or whatever, they're testing leg, whatever, it's strong. Here, hold this pill bottle in your hand. And then they'll retest. Oh, you're weak now. No, probably not. It's not going through the capsule, through the bottle, into your hand, and your brain's getting a response to that. Sorry, don't buy it. Don't buy it for a second, okay? That's not how you take the pill, right? It's ingested, right? So if it's something that we're testing that has to be ingested, typically putting on the tongue's enough. You don't have to actually physically ingest it. Putting on the tongue's enough. And then you can test and see what the brain's response is to that. If it's something that you put on your skin, a skin product, you would apply that to the skin and then test, okay? Don't put that on your tongue. And so we can check for sensitivities or, you know, just things that don't agree with the body in that way. So there is, you know, we can test to see if we have peanut butter. What else? So we utilize these processes, right, to try and make an assessment, see what's going on. Every neuroreceptor dysfunction that you have, whether it's that primary one, secondary one, any of his buddies that he brought along with him, will have an associated muscle fiber with it. Every single one of them. And so we can test for, we might have neuroreceptors that are dysfunctional, but there's going to be a muscle associated with each one of those, right? And so, you know, we put somebody down on the table, and I would go through, I would test, you know, rectus abdominis, transverse abdominis, their hip flexors, their hip extensors, glutes, adductors, big muscle groups, right? See which ones are affected. And you might have multiple ones that are affected. And we say, okay, this one's abnormal, this one's abnormal, this one's abnormal. Keep them mental note. Go back, fix the neuro dysfunctions, and then go back and recheck them, right? That's fine that I can find neuro dysfunction. We can walk out on the street, you can pick out anybody you want, I will find neuro dysfunction on them. We all have them all the time. A lot of times they autocorrect, brain fixes them itself. But if it's anything like my cell phone, autocorrect doesn't always work. It doesn't work the way I want it to, right? So sometimes those don't get fixed correctly, don't get fixed at all, and those are the ones that progress and become symptomatic, right? That's where we start having maybe some muscle weakness, some things that are inefficient, not working properly. We start having pain. If those things continue to progress, we typically get injured, right? But if we can intervene before we get there, then we can prevent that. When we have dysfunction like that, we want to get to the source of it and get there quickly, okay? Before we go down that road. When we start talking about, I see a lot of athletes as well as general population. Start talking about athletes, start thinking about athletic performance, right? So I love my track guys. I do the Augie men's track team. I see a ton of those guys. The national relay track team was in to see me every week last year when they were going to nationals, right? Personal best almost every week. They let me down a couple of weeks, and I got on them about it, but they ended up winning national title. They were coming in every week, and a couple of individual guys too. I love my track guys. I love my swimmers. Why? It's all timed events, right? So if you start seeing a performance drop, you know there's a dysfunction. You know they're not operating efficiently. They're training just as hard, if not harder, than they were the week before, but they're having performance drops, right? Get in to see Matt, right? Oh, okay, well your glute's not working on the right side, and that's affecting your shoulder pull in your lat, or whatever the case may be. Again, we correct those things, and I'm telling you, they do really well. So I like those types of, versus, you know, and I see all kinds, but, you know, my lifters, my CrossFitters to a certain extent, things that are measurable. That, you know, like your football players, maybe your wrestlers, basketball
What
players.
about a wrist?
What about a wrist?
For a quarterback.
For a quarterback?
Mm-hmm.
Could be a lot of problems.
Problems.
Could be a lot of problems, a lot of
Yeah.
different problems. Yeah. So, depends, is it a primary wrist problem, or is it a core stability problem, right? Where he's not stabilizing his pelvis, and now we're trying to shoot a cannon from a canoe, right? We don't have a solid base from here, just like shooting that cannon from a canoe. Canoe goes backwards, cannonball rolls out the end. The only way you get the cannonball to go farther is to stuff more gunpowder in, right? Pretty soon you blow up a cannon, right? So if you don't have good stability here, it's going to affect both directions. It's going to affect your hips, your knees, your ankles, shoulders, elbows, wrists, right? Okay, so stabilizing here. I don't know that that's his problem. I'm just saying that's something that we look at. We look at these big foundational muscles first, right? What can stabilize our core, our pelvis, you know, our abs, our glutes, our hip flexors. Look at all that stuff first. Because if those aren't solid, if those aren't good, and give us a good solid base to work from, if I fix something out in the wrist, it may just come back because we still got an instability there that we got to deal with. So, or is there some structural problem in the wrist that we got to deal with, or in the elbow, or in the shoulder, right? Carpal tunnel, right? So, deal with a lot of carpal tunnel cases. A lot of times it's not a wrist problem, right? It's coming from somewhere else. It could be coming from the elbow, it could be coming from the shoulder, it could be from the neck, brachial plexus. Don't know. I mean, I had a lady that was scheduled for carpal tunnel surgery. It was on the books, like a couple weeks out, comes to see me. Is there anything you can do in the meantime? Start looking at her, I'm like, yeah, I don't think this is a wrist problem. You know? Go up to the shoulder, looking at the brachial plexus, it's getting compressed. Your first rib is dropped, it's compressing the brachial plexus that goes down the arm. That's where our problem is. Fix that. She gets off the table, she's like 75% better. Okay? Not 100%, but about 75% better. She comes back for another visit, she says, I'm probably 90% better. She calls the doctor, she says, I'm canceling my surgery. I don't want you cutting on my wrist, right? I don't think I need it. Doctor calls me, want to know why I told this patient he didn't need to have surgery, he wasn't real happy. I said, I never said that. She figured it out on her own, I guess. But things like that, looking at not just where it hurts at, but what might be causing that, right? And what's kind of interrelated in those things. Covered a lot of things pretty quickly, used a lot of big words. But if anybody has any questions or has something specific they want to talk about, I'm more than happy to do that. Again, we talked a lot about pain conditions, right? And how this relates to pain. But we start talking about the neuroreceptors and the neurodysfunction. All of that's contributing to stress to the body, right? So we start talking about autoimmune, right? All of that's a negative thing for any autoimmune. I don't care if you got Crohn's, I don't care if you got lupus, whatever. If we add stress to the system, we're going to have an improper immune response, okay? And so if we can decrease those stressors, we have less of that improper immune response, right? So we have an overall holistic approach to stabilizing the organism, in this case, our bodies. Right? There's a lot of things that go into that, but this is just one area that's overlooked. Nobody else around here even does anything with, right? And so it's kind of that specialty area where people come to see me. Let's see if we can get rid of some of this stuff, right? Now it's fine that I can find dysfunction, I can fix it, but the dysfunction may not be related to your symptoms, right? And so that's why I tell people, I say, I don't really treat pain. They're like, are you kidding me? That's why I'm coming here. That's why I drove 3 hours from Chicago to come see you, just to fix my pain. I said, well, I fix the neurodysfunction. Now, if that's what's generating your pain or contributing to your pain, then your pain's probably going to get better. And oftentimes it is. But sometimes it's just not related. Sometimes it's not even symptomatic yet. We just happen to find dysfunction. Again, so we go out on the street, we can find people that have dysfunction. So what do? We go back and we retest. We say, are things improved, right? And then how are your symptoms, right? Oftentimes if people have a condition that's related to a neuropathway dysfunction and we fix the neuropathway dysfunction, get off the table, wow, 75% better, 100% better, whatever. Sometimes it takes a little while to see those results because maybe your pain's not directly related to the neural dysfunction, but maybe it's related to the inefficiencies that was caused by the neural dysfunction. Right? So we got rid of that, we got rid of the inefficiencies, but you've been inefficient for a long period of time. That's where you need to see a trainer, right? Maybe you get things back to where you need to be. And then you're being So that's why we tend to work with a lot of other practitioners around town as well too. So again, if anybody has any questions, anybody wants to talk afterwards, I'll be available to do that. We covered a lot of stuff pretty quickly. I think I kept it
No, you can look at my protocols I've got going on.
we'll take a look at it.
Can I ask, so you're, is it strictly referral basis or are you taking
I do take new patients. I mean, the schedule's a little tight these days, but yeah, we get people in.
how far out are you?
A couple, 3 weeks.
And then the initial visit, is it like an hour and a half? Or an hour?
Typically, I schedule about 45 minutes.
Here's a gut one.
Sometimes that works.
Yeah.
Sometimes it takes a little longer, depending on the complexity of your problem. But I schedule 45 minutes.
Do you accept insurance?
I don't bill insurance.
Okay.
Right? I can give you an invoice that has the insurance codes on it. You can turn it into your insurance if you want. But I don't staff anybody to bill insurance.
So then, other than, you know, maybe finding strength in a more balanced program through a trainer, do you have some of your patients do therapy exercises at home to help strengthen?
Yeah.
Areas?
Yeah, and they do, and they're extremely targeted for whatever the issue is. And we work them in pairs, okay? So we work on these where the dysfunctional areas were. So I give them like a setup, almost type of thing. So we do a release in a certain area. I teach them how to do that themselves, or using like a tennis ball, a cross ball, something like that, right? We get a release first, and then an activation of an associated weak muscle, right? And so that'll help. Not just training the muscle, we're also training the neural pathways, because sometimes those have been dysfunctional for a long period of time, and they got to be conditioned, just like our body does. And so we, through repetition, we try and reinforce some of the work that we did in the office. The exercises that I give, again, are very targeted, and they typically are very short, because I'm more interested in that neural pathway than I am like muscular endurance type of thing. If the neural pathway comes along and is really healthy, the rest of it's going to come along just through normal activities. So typically when I assign a particular exercise for somebody, it's less than 5 minutes. Okay. Compliance rates are really high with that versus, say, a typical PT program, right? There's half hour, 45 minutes or something like that. It could be the best PT program in the world. The patient's not going to do it. Compliance is poor. It's not the right one for them. 5 minutes, I can get you.
Yeah. That's a really good point. I have a daughter
You
that's
understand that?
doing that right now.
Yeah, I mean,
Yeah.
it is what it is.
A lot.
The more complex a medication regimen is, the less compliance you get. The more complex or longer a PT program is, the less compliance you get. The more compliance you get, the better it is. Again, you can have the best medication in the world, you can have the best PT program in the world. If the patient's not going to do it, it's not the best one for them. They're not going to get the benefit from it. So we have to modify and treat people individually. Okay?
Are you a chiro too?
I am not.
Yeah.
I get that a lot, but no. Not a bone cracker, as my Amish friends would call it.
Back cracker.
Back cracker, bone cracker, whatever. It's funny, the Amish community that I go to, there's a town this way and a town this way. It's about equal distance, and it takes about an hour by horse and buggy to get there. There's a chiropractor in each town.
Really?
Half the community was going to see Dr. Troy over here. Half the community was going to see Dr. I don't know who it is over here. This half got tired of seeing Dr. Troy, so they switched over here. This half got tired of that guy, and they're going over here to see Dr. Troy.
Troy Eaton?
Now, Troy, Sherman, something like that. Way down southern Iowa, almost to Missouri. And so it's kind of
Along Amish and Postville and
Yep.
northern Iowa.
Yep, yeah, there's
Go
a lot
there
up
a
there.
lot.
Yeah, we go up to Waverly sometimes. Yeah, so.
What's, I don't know what NKT.
NKT is neurokinetic therapy,
Okay.
so it's just another modality that I utilize.
And
And
in ART?
that's the active release techniques.
Oh, okay, gotcha.
Yeah. Again, that's more hardware based,
Mhm.
structural, fascia, muscles, tendons, that kind of
What was you just doing? Was that like a neural?
Yeah, so that's more of a neuro software type of treatment. Right?
So that wasn't specifically ART.
It was not ART at all. Not at
That's what
all.
I thought. I saw your ART and
Oh yeah, that's the shirt I had on.
I know, it doesn't stand for art.
Yeah.
How long has it been since 3 months?
And that was after the first of the year. Yeah. Somewhere around there. And then, so what have you seen different?
I feel, the one thing, honestly, this is kind of crazy, but I do feel like a little bit more at ease about stress, the way I handle it. Like I'm not gonna be a crybaby, a ball baby. That makes sense. You know what
that's
I mean?
good.
I feel like I don't know, it's kind of, I
I
don't
mean, to
know.
put you on the spot, but
No, I mean, that's one thing I noticed, like I feel like my emotions are a little bit,
so
You've
I mean,
got,
so start thinking about that, right?
You've
So if
gotten
you're
tougher.
taking away some of the stressors to the body, you're going to be able, you have more capacity to deal with stress, right?
I gotta squeeze, but this has been interesting. I'm gonna call your office and schedule.
Well, come on down anytime.
yeah.
Actually, we're doing a talk tomorrow night, actually at my office at 6 o'clock.
Is it at your office?
Is it listed?
It's downtown Davenport.
Or functional
It's,
Or, yeah.
You did something.
Vim today?
yeah, I've done some Vim talks too.
What's your talk on tomorrow?
It's gut and the microbiome as it relates to pain.
And when does that start?
6 o'clock, 6 p.m.
But where's your office?
6 to 8. It's the U.S. Bank Building, downtown Davenport, so 2nd Main Street. So Dr. Shaw is going to be coming in talking about gut microbiome and how that plays into pain conditions. And then Dr. Sarah Rauch, who's a good friend and colleague of mine, she's a chiropractor. She's going to be talking about chiropractor and acupuncture that relates to pain symptoms.
I really want to go to that, but I work till 7, so I'm trying to see if I can get off.
there's a lot of gut crap going on.
There is.
I mean, they're starting to
It's an
do
epidemic.
research on it and
So
saying-
where's it located at?
U.S. Bank Building, so it's 2nd Main, right downtown
No.
Davenport.
I don't know what it got something.
Gut
No.
microbiome.
They're a lot of things like Alzheimer's and all that
Alzheimer's,
stuff.
Parkinson's disease,
Yeah.
Autoimmune disorders. You can go, the list goes on and
Well,
on.
I have lymphocytic colitis, which turned into enteropathic colitis, and now they think I might have some lupus and involved in that, so
Okay,
I'm on a lot of infusions. Lisa knows that
Sure.
I'm on a lot of stuff.
sure, sure.
Too much.
Too much,
Too much.
too
Yeah.
much.
So,
So
How
I'm
many
really
infusions you had
interested.
lately, Chunky? Yeah.
yeah.
I'm back on them.
0. Yeah.
Mhm.
Well, it's a, it's a process, right? And,
It's working, but some of the side effects
right.
are
Some of,
horrible.
some of the side effects can be worse than what we're actually treating,
Yeah,
right? So our goal is, can we reduce that? Can we eliminate some of those things? Can we eliminate all of them, right? What I found is it takes a very multifaceted approach to that. Again, there's typically not a silver bullet. Unfortunately, that's what people are looking for sometimes, right? Is that silver bullet. But most of these things that we're dealing with, it's multifaceted. There's a nutrition component. There's almost always an emotional component. I'll guarantee there's an emotional component with anybody that's dealing with any long-term illness,
Absolutely.
right? There's frustration, there's anxiety, there's depression,
Yeah.
there's these emotional components that just cycle back around to create more inflammation, more problems, and we get stuck in this cycle. So we have to address the emotional side of it. We got to address the nutritional side of it, the software neural pathway side of it, right? That nobody else is addressing, right? So that's something that needs to be addressed. Are there structural issues? Are there things that we haven't looked at yet? We got to address it all together, and that's where I see the biggest results, right? Where we can start getting off of some of this stuff or not needing it, right? And it's a process. It takes a while.
That's what I think, what I'm doing is the components, all the components, and the key being one of them, you know what I mean? Like, have this full spectrum on the wheel that I'm getting together.
Right. And it can get to be like, boy, I'm going to see Matt, and I'm going to see Sarah, and I'm going to see Shaw, and I'm going to, it might be what it takes.
but I'd rather do that than to be on all this medicine.
And we want to see you there. Trust me. I don't like seeing that for people, right? because the long-term effects of what we're dealing with there, in some cases, might be worse than what we're treating. Right? So we don't want to do that. So if we can help with that, we're happy to do that. We'll try to do what we can. Very welcome. Thanks for coming.
Thank you.
Thanks
You
for
wanna
having
fill
me.
this big knot?
Sure.
Yeah. So let me know.